There are about, I think, 56 short stories and 4 novels or novellas. And Sherlock Holmes must be the most popular and most respected fictional detectives of all time. So we'll use his persona in this short 30-minute presentation of 4 cases that he would have given the correct lab report, even if the lab report was mistaken because of iron deficiency. The plea to stay patiently outpatient. This is a very simple case, and you will probably get the answer very quickly. What happens is this: Sherlock Holmes, who's now a doctor, by the way, Dr. Watson has taught him enough, and Sherlock Holmes now receives a CBC report of a terrified dengue patient. You'll have to guess which important drug is missing, and therefore which abnormal blood test resulted in that drug going away.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like video so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside. Good evening, everyone, and welcome to today's session. I am Dr. Sanitra, and I welcome you to Solving Medicine with Dr. Tushar Shah. Today, we are starting with a brand new series. It's an interactive medical quizzes, and with today's session, we are trying a new format of an interactive detective-style medical mystery show. So we want you to join in, play along, and keep engaging throughout the session. And for this, we have none other than Dr. Tushar Shah. Without further ado, over to you, sir.
Thank you, Dr. Sanika. Thank you so much. Okay, so yeah, we all know Arthur Conan Doyle, a physician of Scotland, and we all know that Arthur Conan Doyle wrote the character of Sherlock Holmes and his associate Dr. Watson. There are about, I think, 56 short stories and 4 novels or novellas, and Sherlock Holmes must be the most popular and most respected fictional detectives of all time. So we'll use his persona in this short 30-minute presentation of 4 cases. So let's begin. In this whole thing, there'll be some polls. So we would like you to take part in the polls so that we become a very interactive session. The first case is what is called the scandal in anemia. Well, this is just a takeoff on the first short story of Sherlock Holmes called The Scandal in Bohemia. So we have the scandal in anemia here. Okay, so what happens here is this. There is this lady who comes with a complaint for about her husband, and she tells Sherlock Holmes that, look, this is my hemoglobin electrophoresis report, where clearly, if you enlarge this report, the hemoglobin A2 is 3.67, and I am a beta thalassemia trait, something that I declared to my husband before we got married. They probably are of the same caste. They are Luhanas, or maybe Parsis, or maybe Boris, but they they come, the husband accompanies the wife. The husband is denying any false doing. The wife gives the report of the husband. She says, this is the report my husband gave me before we got married, and this report says a normal hemoglobin A2 of 2.7%. Now, as you know, in thalassemia minor, the hemoglobin A2 rises slightly, and 3.2 or above, or in some reports, some labs, 3.5% of the total hemoglobin, if it is hemoglobin A2, is considered thalassemia minor. So, thalassemia minor, husband, thalassemia trait, wife. And so the wife says, okay, we are safe to marry each other and conceive children naturally. And somehow in their religion, they said that we are not allowed terminating pregnancies at any stage. So that's why the importance of not marrying a thalassemia trait for her. So these two reports are there with Sherlock Holmes, and the child has turned out to be thalassemia major. Now that came as a shock to the mother, a surprise also to the father. That's what he claimed, and the mother comes asking for compensation and divorce from the father, and they come to Sherlock Holmes for the consultation of the same. It was a scandal, according to the wife, a scandal of anemia. The wife has already served a notice. The notice is a divorce petition to the husband. Uh, what does Sherlock Holmes do? All he does is this. He says, "Dear sir, do you have piles?" Now, the problem to you, the audience, is why does Sherlock Holmes say to the husband, "Do you have piles?" Which means he obviously assumes that there is this problem with the husband. Why does he do that? Let's have a poll on that. Be ready. Your question to you is: did he say this because of iron deficiency? Can we start the poll in a? Can we kind of okay? Did Sherlock Holmes say this about? I think, Sanika, we are a little too early. I should have completed the question because we won't get time to answer. Can you try again? Can I go back? Okay, the answer has been given. So I'll just come back. So Sanika, just give us. I'll tell you when to go for with the poll so that they get a time to read the question. Okay. So why did Sherlock ask about piles? One, because iron deficiency due to piles may have caused a false negative thalassemia test, or because he wanted to encourage the wife to get divorced for not one but two reasons: piles and the thalassemia false report. So, as some of you have already answered, the correct answer is he asked about piles because he did trust the husband that he would have given the correct lab report, even if the lab report was mistaken because of iron deficiency. So, iron deficiency because of say piles or any other reason can mask the thalassemia trait by falsely reducing the HbA2 levels. So this is very important because sometimes, especially in a situation of marital counseling, if the parents have one of the parents has a thalassemia trait, and you find that the son or daughter don't have a trait, which is a good chance to have actually. So if that happens, you may want to recheck by first checking the iron levels. If the iron levels are low, either ferritin or transferrin saturation low, correct the iron. After correcting the iron, check for the thalassemia trait again. And as you know, the check for the thalassemia minor is doing a protein electrophoresis for beta thal trait, sorry, hemoglobin electrophoresis for beta thalassemia. And if that electrophoresis shows HbA2 of 3.2 or more percent, then we have thalassemia minor. So I hope this is clear, and if it is not, we can take the question again during the last Q&A. So here, the husband and wife have been brought together again by Sherlock Holmes' simple question: do you have piles? Let's go to the second question. Second case. This is the explanation that I've given here. Iron deficiency is known to suppress HbA2 synthesis, potentially leading to a normal or borderline low HbA2 and mass of thalassemia trait. Upon correction of iron deficiency, HbA2 levels rise and unmask the beta thal trait. So this is what happens. I'm not going into details now. We'll take this up during the Q&A. If yeah, there are two beta thalate people who marry, then and have kids, then as you know, there is a 50% chance that the kid will have a trait, 25% chance that the kid have a no thalassemia trait, and 25% that they will have a thalassemia major. And can you make out if two beta thal partners conceive a child? Then can you make out that if the child is thalassemia major? Yes, you can by doing either chorionic villus sampling at 10 to 12 weeks or amniocentesis at 15 to 18 weeks gestation. Can they do something about it? Both of them are trait and they want a child naturally. It is difficult in India. We don't have all the technology, but what can be done is that they will do an IVF but get a donor egg. The sperm will remain the natural father's, and there will be a donor egg to replace the natural mother's ovum. So that is one method of preventing thalassemia major. Let's go to the second case. The plea to stay patiently outpatient. This is a very simple case, and you will probably get the answer very quickly. What happens is that Sherlock Holmes, who's now a doctor, by the way, Dr. Watson has taught him enough, and Sherlock Holmes now receives a CBC report of a terrified dengue patient. The platelet count is 12,000, and Holmes asks him just one question and then advises against hospitalization. You have a choice of these two questions. The first question that Holmes asks is, what active bleeding do you have, if any? Do you have any active bleeding? And second question is, what day of fever is this? So here is your two questions, and you will have to take the poll. What did Sherlock Holmes ask? Sanika. Yep. This is about a dengue patient whose platelet count is 12,000. And Sherlock Holmes says no to admission based on the answer of this question. What question did Sherlock Holmes ask? Okay, we are divided here, very, very close division, and I expected this division, and I hope my explanation satisfies you. The question that Sherlock Holmes asks is just this: what day of illness is today? The reason he asks this is, if the platelet count is 12,000 on the seventh day or the eighth day of illness, when the fever has probably already gone, then the platelet count is at its nadir, is at its trough, and the platelet count is not going to harm the patient, the low platelet count. Why do you say that this is not a good question to ask and bleeding is a good question to ask? Well, let me tell you that if the platelet count is 12,000 on day 4, even if there is no bleeding, the patient has to be hospitalized, because we expect the platelet count to continue falling for about 7 days till the fever that is lasts, and therefore any platelet count of low of maybe 20,000, 30,000, even on day 4, must be hospitalized. So which is why the day of illness is more important than active bleeding to decide about hospitalization. That was your case 2. Let's go to case 3. This is the matter of the long prescription. This is a polypharmacy case, and this patient has HFrEF, heart failure with reduced ejection fraction. Let me explain what is HFrEF, and then also what is HFpEF. Heart failure with reduced ejection fraction is when the ejection fraction is below 50%. Some people classify it as below 40%, and 40 to 50 is classified as a medium range heart failure. But for our practical purposes, for our management purposes, heart failure with reduced ejection fraction is any heart failure which has a abnormal systolic function and EF of less than 50%. Many people say less than 40%. Okay. Now, what is half HFpEF, heart failure with preserved ejection fraction, is when the ejection fraction is 50% or more. That is heart, and there is heart failure. So this heart failure with preserved ejection fraction. Both have completely different areas of management with one overlap. So let's go to this prescription first. See the prescription carefully, because this prescription, all the questions are based on this prescription, and all the questions are slightly tricky and require some deduction of the kind that Sherlock Holmes specializes at. Okay, so you can enlarge this prescription with your fingers, and if you enlarge it and if you see, this prescription is a classic HEF ref prescription. The patient is currently asymptomatic, important, currently asymptomatic, 75 male, sacubitril valsartan, that is ARNI, then metoprolol, empagliflozin, furosemide, an aspirin clopidogrel rosuvastatin combination, a bempedoic ezetimibe combination, and digoxin. This is the complete prescription. Of course, there are supplements, but this is the principal prescription. The first question is an obvious question. I've already answered this. So this is the kind of question which we will ask. What is the patient's LVEF? Is it low or is it normal? And I have already said it is HFrEF, and therefore it is a low ejection fraction patient. And how do you know from this prescription alone that this is a low ejection fraction? The first three drugs may be a clue, and the fourth drug, furosemide, also. We don't use ARNI in HFpEF. We use ARNI only in HFrEF. That is, for example, one of the many clues that this is HFrEF. Okay, so this is the first question. Now let's take the poll. Can we do a trial poll here for the audience? What is the patient's LVEF? Audience, let's see if you can do the poll, and then we'll go to the second question. Okay, so thank you. Some of you purposely gave a wrong answer so that the poll looks really like a poll. So this obviously case has a HFrEF or reduced ejection fraction. Okay, let's go to the second question, and we'll be directly going to the poll. The question is simple. What is the cause of low LVEF in this patient? Ischemic or dilated cardiomyopathy? Ischemic with abnormal coronaries, dilated with normal coronaries. What is the cause of low LVEF in this prescription? And the prescription probably will come to you on the screen, because okay, the poll is not visible. Right now, the poll is visible again, and if you click on the image, then you will get the prescription again on the image, just in case you want to see the prescription again. Okay, the poll, the answer says ischemic cardiomyopathy, and please click on the image, and I will again see the prescription and tell you why we call it ischemic. Okay, we could have kept that if possible, but anyway, I'll go back to the prescription. This is the prescription. Why do we say that this is ischemic cardiomyopathy and not dilated cardiomyopathy with normal coronaries? We say this is ischemic cardiomyopathy because the most important thing here is there are two antiplatelet agents with a statin here. Antiplatelet agents are not typically given in a combination or DAPT, that is dual antiplatelet therapy, in dilated cardiomyopathy with normal coronaries. So here we are dealing with an ischemic cardiomyopathy and not a dilated cardiomyopathy. I hope that is satisfactory. And let's go to the third question. Again, I'll repeat, you can click on the image button at the pole side and therefore get the prescription again. I'll also try to give you the prescription on the screen here. What abnormal blood test resulted in the omission of an important drug? You've seen the prescription. One important drug related to HFrEF was not there in the prescription, which was omitted because of an abnormal blood test. Tell us what abnormal blood test. Can we start the poll now? It was high creatinine or high potassium? Again, you can click on the image and get your screen telling you what drugs are there on the list. First of all, you will have to guess which important drug is missing and therefore which abnormal blood test resulted in that drug going away. Yep, you're right. You got that right. High potassium is the reason why the SGLT2 inhibitor was omitted. Sorry, I'm so sorry. Why aldosterone antagonist, spironolactone was omitted. So MRA, mineralocorticoid receptor antagonists, are an important component of the therapy of HFrEF, and if you don't have that, it was omitted because of hyperkalemia, not because of azotemia. And in hyperkalemia, the first drug to go will be spironolactone or eplerenone if it is there, and not valsartan sacubitril, because sacubitril is an important, probably first line drug for HFrEF. So if you have to sacrifice something for high potassium, it'll have to be spironolactone. Okay, I think you got that right, and let's go to the next question. Those who have just joined, I'll just repeat. This is a prescription given to a 75-year-old male, and he's being treated for HFrEF, heart failure with reduced ejection fraction. And we are asking questions based on this prescription. You have to do some deductions about the patient's diagnosis, about the patient's therapy based on this prescription. So let's go to the next question. We first asked what is the patient's LVEF, and it is low because we saw on the prescription ARNI, which is not given in HFpEF. We saw the cause of low LVEF as ischemic cardiomyopathy because the patient is on dual antiplatelet drugs. And we just said that an important drug, spironolactone, is not there because the patient must have had a high potassium as a side effect. Okay, so now your next question is, what arrhythmia has the patient suffered? Deduce it from the prescription. You will see the prescription again on your screen. Click on the image button. But is it atrial fibrillation that the patient suffered or ventricular tachycardia? Let's have the poll. Patient has been on ARNI, metoprolol, empagliflozin, furosemide, aspirin, clopidogrel, rosuvastatin, bempedoic, ezetimibe, and digoxin. What do you think is the arrhythmia that the patient had? Majority got it right. Yes, atrial fibrillation was the arrhythmia that the patient suffered. What is the reason? Let's go back to the prescription and see. If you see this prescription, enlarge it if you like with your fingers. If you see this prescription, it has digoxin. Digoxin, which in olden times, when I was young in my college, was the staple, the principal drug used in heart failure with reduced ejection fraction. Digoxin is now not used anymore in a standard HFrEF. It is used only if HFrEF is associated with atrial fibrillation. And here it is used to control the ventricular rate. So digoxin implies atrial fibrillation in this patient. And it's not just one single episode of atrial fibrillation. It probably means that it is chronic atrial fibrillation or a recurrent atrial fibrillation. Another reason why atrial fibrillation should be the correct answer is that in HFrEF, a common cause and a common effect of HFrEF could be atrial fibrillation. Atrial fibrillation, one thing that is common to HFpEF and HFrEF. Very important to know that HFpEF itself can be caused by or worsened by atrial fibrillation. So, atrial fibrillation is an important arrhythmia in heart failure, and atrial fibrillation is an arrhythmia which we generalists are not very comfortable managing, and but we should know more and more about management of atrial fibrillation in heart failure. Okay, so that takes us to the next question. Let's see what the next question is. Would the cardiologist advise prophylactic placement of an cardioverter, an implantable cardiac defibrillator in view of an EF of 35%? The EF of 35% in this patient is, I'm declaring it first time now, EF is 35%. Patient has a reasonable expectation of more than 1 year survival. Typically, any patient with low EF in HFrEF is advised ICD placement in certain conditions. This patient, if you heard the history properly, this patient, would the cardiologist ask for the placement of an ICD? Let's take the poll. Yes or no? Prophylactic placement means the patient has never had a VTAC or VFib, and now the ICD is being placed to kind of shock the VTAC VFib if they do occur, because the VTAC VFib occur more commonly in a poorly functioning left ventricle. Would they advise? And many of you have said yes. It's the wrong answer. The very important thing here is the first statement, first history. A currently asymptomatic 75 male. In HFrEF, an ICD is placed only if the patient is symptomatic. An asymptomatic, the benefit in an asymptomatic is not significant. So, if the patient has had maybe a VTAC before or a VFib before, or has had to, has had a external conversion, cardioversion done for a certain cardiac arrest, then yes, you may have to put. But if the patient has not had any such thing and is currently not even breathless on walking within the house, or what we call grade 2 symptoms of heart failure, then there is no indication of putting in an ICD. Okay, so let's go to the next question, and that is this one. Did the patient suffer an acute coronary syndrome or had a PCI in the past? PCI refers to percutaneous intervention, coronary intervention, and that means an angioplasty or etc. So, do you think this patient had one? And if so, say yes. Or if not, if you're not certain, say B. Let's see. Take the poll, please. This particular patient, did he suffer an acute coronary syndrome? Okay, most of you said yes, and that is correct. Patient, remember, is on a dual antiplatelet drug combination. So probably he suffered an atrial fibrillation, an acute coronary syndrome, and that is why this DAPT is going on with a statin, of course. So yes, a question would be, why is a patient not on an anticoagulant, a NOAC, uh, despite the fact that the patient had atrial fibrillation? There is one debate that we can have. Let's go to the next question first. In the ARNI combination, which component is the active ingredient that improves heart failure? Active component in sacubitril or valsartan? Which one is the active component? Let's take the poll. all of you, most of you again got it right. Sacubitril is the main component, and sacubitril is given for its value. Sacubitril is a neprilysin inhibitor. Neprilysin is an enzyme. Neprilysin enzyme that inactivates BNP. Uh, that means that it does not allow BNP to do its work. What is the work of BNP? BNP is a natriuretic is a natriuretic hormone, meaning it does natriuresis along with the salt loss. It causes water loss, and uh, it also causes vasodilatation. So it works for heart failure, BNP. Now, neprilysin neutralizes BNP, and our sacubitril neutralizes neprilysin. So BNP levels rise, helping heart failure by diuresis, natriuresis. Now, that is what is the function of sacubitril. And why is valsartan added to sacubitril? Anybody? Let me see if. Okay, the answer is given in the next slide. Valsartan is an angiotensin receptor blocker like telmisartan, olmesartan, etc. Why is it added to sacubitril? Sacubitril, which inhibits neprilysin, by inhibiting neprilysin, it also inhibits the formation or the destruction of bradykinin. I'll repeat this. Neprilysin is an enzyme. It deactivates BNP. It also deactivates bradykinin. If neprilysin is inhibited, bradykinin levels rise. A rise in bradykinin levels has side effects. The principal side effect being cough, the other side effect being angioneurotic edema. Valsartan, by inhibiting the angiotensin receptor blocker, will not allow bradykinin to rise. Can we add an ACE inhibitor here? No, we can't. An ACE inhibitor will probably worsen the angioneurotic edema caused by bradykinin. So, valsartan is added for this reason. I might have made a mistake here. It's inhibiting neprilysin alone would also increase the level of angiotensin 2. I'm so sorry. Angiotensin 2 is another enzyme, another chemical broken down by neprilysin. So neprilysin inhibition causes the increase in levels of angiotensin 2. Now angiotensin 2 is a vasoconstrictor, and being a vasoconstrictor, it is detrimental to heart failure. Therefore, an ARB, like valsartan, essential to block the harmful effects of angiotensin 2. I'm very sorry, I made a mistake there. So this is the role of valsartan. So valsartan is not the active drug here for heart failure. Sacubitril is the active drug. Valsartan is just supporting sacubitril by not letting angiotensin 2 to rise. So this is your case number 2. Now let's go to case number 3. We call it 3 is a crowd. Now this 3 refers to 3 physicians of different specialities. And how can 3 physicians cause trouble to one patient? एक दरवाजा खोलेंगे, डॉक्टर ओमकार आए. Just a second. Okay. As you know, we are in a world of super specialists. One patient will go to multiple doctors for different symptoms, and sometimes they suffer for that, especially when one doctor does not know what the other is giving or doing. So let's go to this case, a very interesting case. This lady was under a cardiologist for conservative management of chronic stable angina since 3 years. She was under a dermatologist for a long-standing nail infection since about 4 weeks, and she was under a pulmonologist for an infection for the last 5 days. So, cardiologist for stable angina, dermatologist for a nail infection, pulmonologist for a chest infection, and she dies. She dies just before the death. This is the tracing that she has on her EKG or ECG. Well, if you know this tracing, you will probably be able to answer the next questions. The cause of death given on the death certificate was VTAC, ventricular tachycardia, due to coronary artery disease. But in their hearts, the physicians knew that the cause of death was something else. It was, in fact, a triple whammy from three specialists. Your question: what was the drug for chronic stable angina given by the cardiologist that became the first nail in the coffin of this patient who died of this arrhythmia? This arrhythmia caused by the first nail, bisoprolol or ranolazine. Let's start the poll. Remember, this drug is chronic stable angina drug and given by the cardiologist. Okay, so most of you probably got that right. I'll not give the correct answer yet, but ranolazine is what most of you have said. That was it the first nail in the coffin? Probably yes, but let's go to the next question. What disease did the dermatologist treat her for? Let's take a poll. What did the dermat treat this patient for? The patient who died of an arrhythmia which was labeled as ventricular tachycardia. Okay, so I'll have to give that to you. Most of you said onychomycosis, fungal infection of the nails, and you're right. Uh, let's see what is the third question. What drug did the dermatologist prescribe that was this? I'm so sorry. This onychomycosis was given which drug of these two? And this drug became the second nail in the coffin, fluconazole or itraconazole. Okay, again, most of you got that probably correct. Itraconazole. Okay, let's go now to the third specialist. So remember, we got the first specialist, the cardiologist, who treated her for chronic stable angina, and you said ranolazine was probably one nail in the coffin. Then the dermatologist who treated her for fungal infection of the nails, and you said itraconazole was the second nail in the coffin. And now there was also one more specialist in the picture who since 5 days has been treating this lady with what is called a walking pneumonia. And what infection that is called a walking pneumonia did this lady have? Mycoplasma or pneumococcal? Walking pneumonia, so called because the patient is walking with a pneumonia, is not bedridden, not very weak. Again, most of you got that right. A walking pneumonia, the name is given to usually atypical pneumonias, one of which is mycoplasma pneumonia. Pneumococcal pneumonia, of course, is a typical pneumonia. And that takes us to the last question here, probably. What drug did the pulmonologist prescribe that was the last nail in the coffin? Meaning, for the walking pneumonia, what was given by the lung specialist to this patient that became the last nail in the coffin of this patient? Let's take the poll. Absolutely. Clarithromycin was the last nail in the coffin, and this patient died uh, right after taking this drug from the pulmonologist. Let's see what happens. I'll just go back to the first ECG of this patient. This patient who died because of three consultants giving three different drugs, all three of which would cause QT prolongation, and these three drugs caused this arrhythmia called the torsade de pointes. Torsade de pointes is a ventricular tachycardia which occurs due to QT prolongation, and QT prolongation can occur due to drugs, and the notorious drugs are ranolazine in chronic stable angina, itraconazole amongst the antifungals, and clarithromycin amongst the macrolides. There are many drugs which cause QT prolongation, but I've chosen these three just to tell you that this can happen. This is not something that will never happen. It is not difficult to imagine that a lung specialist will give clarithromycin without knowing that the patient is on itraconazole, and the patient will not tell the lung specialist that I am taking itraconazole for nail infection or any fungal infection. Similarly, a patient of chronic stable angina who's on polypharmacy, the pulmonologist may not realize, or the dermatologist may not realize that ranolazine is a drug that causes QT prolongation. So important, therefore, for every prescriber, especially in a polypharmacy situation, to look for drug interactions. And it's not difficult now. You just have to take a photograph of the prescription, put it on, say, ChatGPT or Perplexity, and ask them, are there any serious drug interactions that you can notice in this polypharmacy? Not very difficult at all. It just takes a few seconds by us, and that can really allow us not to harm the patient. Okay, so that is your. This is one table that I like very much. Itraconazole, clarithromycin. Both these drugs are strong CYP3A4 inhibitors. CYP, cytochrome P450 enzyme system, is an enzyme system in the liver, as you know, which either activates prodrugs or inactivates drugs, and basically it is one of the most important enzyme systems in the metabolism of the medicines that we take. Now, CYP3A4 is a type of enzyme which probably takes care of 50% of the drugs that we take, and CYP3A4 is inhibited by certain drugs. Clarithromycin, itraconazole are examples of those drugs. And say even grapefruit juice, for example, inhibits CYP. This inhibition of CYP allows raised levels of certain drugs that are otherwise inactivated by 3A4, rise when itraconazole is given or clarithromycin is given. And therefore, if that happens, then you can have uh, the rise in level of ranolazine, which causes QTc prolongation, rise in the level of ivabradine, which causes bradycardia, etc., etc., etc. So this is a very important, and you can take a photograph of this. Any patient you give itraconazole, any patient you give clarithromycin, please check for the other drugs that the patient is taking. I have I have great dislike for clarithromycin. I think in every case of atypical pneumonia, you can replace clarithromycin with azithromycin and get similar results, or even doxycycline, for example, for that matter, and get good results. The only situation where clarithromycin is used, of course, there are some esoteric infections where it is used, but in, say, H. pylori, it is used. But again, we now know that in H. pylori, clarithromycin has become more and more useless because of the drug resistance. And so I think clarithromycin is something that we can almost always do away with. Itraconazole, it is difficult to do away with itraconazole because the current situation where fluconazole is not working, ketoconazole oral is banned, and itraconazole therefore is an important drug for us. Therefore, take great care when you prescribe itraconazole. Look for drug interactions. Okay, that's all from my side. Thank you so much, and I hope that this was an experimental thing. I made a couple of mistakes, but I hope that this is something that Medflix will continue doing, using more interactive. And as Medflix, Dr. Rohan Desai told me that Medflix has now a significant technology backup to do experiments, and we will try keep on doing such experiments with you. Thank you. Dr. Sanika, if you're there.
Yes, sir. Thank you so much.
Thank you. Thank you so much.
Yes, we'll take a couple of questions now. In the meantime, there have been a lot of appreciative comments in the chat box for you. And thank you so much for this excellent session.
Thank you. My pleasure.
So, while we wait for more questions, sir, if you have a few insights that people should remember in their clinical practice from these cases.
Uh, I'm sure many people came late. So one thing that the first case that I discussed was about beta thaltrate. So one important message there was that the test for beta thaltrate is hemoglobin electrophoresis, and the HbA2 in beta thaltrate is more than 3.2%. Now, HbA2 is a component of total hemoglobin that rises a little bit. It's normally 2.5 to 3.2% or so. It rises a bit in beta thaltrate, but if the patient is iron deficient and has beta thalassemia, the iron deficiency does not allow the HbA2 to go beyond that 3.2 demarcation. Hence, in an iron deficient patient who also is beta thaltrate, you may get a false negative hemoglobin electrophoresis. So be very careful when you have such a situation. Uh, if beta thaltrate and iron deficiency are together, the MCV falls even further below what you expect MCV to fall in each individual case. So very low MCV, you can think of beta thaltrate. If there is a beta thaltrate situation where the RDW, the red cell distribution width, is larger than, because in beta thaltrate the RDW is normal, but if the RDW is larger, then again you have to think of two things overlapping. So that would be one important message from the first case. The second case had, of course, dengue. The important message was that the day of fever or illness is important in judging whether the platelet count is low enough for hospitalization. So, as we know, in dengue, fever lasts 7 days. The platelet count keeps on falling till the last day and beyond the last day sometimes. And therefore, once the patient is getting better, the actually may be very low, and that should not make you panic. So even at 10,000 platelet count, I have refused admission if we are on the 7th, 8th day of illness. Yeah. Dr. Sanika.
For the first case, we have a question here by Dr. Preeti. Is there a HB level defined below which false negative low HbA2 can be expected?
The Is there a hemoglobin level below which? No. Hemoglobin level will not determine probably false HbA2, and deficiency will. So I think if the hemoglobin is say 6, and that hemoglobin is 6 due to B12 deficiency, that will not mask the hemoglobin electrophoresis and give a false negative result. So it's not the HB level, it's the iron level which will decide false negativity.
Yes. We have Dr. Batul Bora's question next. Why does combining digoxin with loop diuretics increase the risk of arrhythmias even if digoxin dose is unchanged?
Even if digoxin doses,
Unchanged.
I will. I'll do this answer, assuming the question to be what I think it is. Hypokalemia caused by a Lasix, that is the furosemide, or any diuretic, loop diuretic, increases the chances of digitalis toxicity. That is one thing that you might know. Secondly, azotemia caused by furosemide, that means a rise in creatinine caused by furosemide, will also worsen toxicity of digoxin. What does digoxin do to the potassium? Digoxin raises the potassium. Hyperkalemia is a side effect of digoxin, unusual side effect of digoxin. So I hope, I don't know whether you can get your answer from whatever I have said. But if you want more clarification, please go ahead.
Okay. Let us know, Dr. Batul, in the comments. In the meantime, so Dr. Mahadev Desai sir has asked your comments about alpha thalassemia trait.
Alpha thalassemia is a subject that I am very unknowing about. So, Dr. Mahadev, you'll have to teach me what is alpha thalassemia trait and how is it diagnosed. Abnormal hemoglobins, I'm poor at. I know of course, there is Cooley's anemia, which is thalassemia major. Uh, I know a little bit about sickle cell, but alpha thalassemia, I don't know what the structure is like of the hemoglobin, yeah, the abnormal hemoglobin.
Yes, sir. All right. I think so. That is all the questions. And Dr. Batul has said thank you for your answer.
You had
We have a couple of more minutes, so if there are any questions you have to ask, so let us know.
Also, if you have any suggestions on the formats that the technology of Medflix allows, if you have any interactive, especially session that you would like, let us know.
Definitely. Please let us know your feedback on this session as well as what we can incorporate in the upcoming sessions. Uh, Dr. Gunjan Patel has asked, what is a healthy approach to CBC report? So a quick, not an entire session maybe.
What report? CBC? Okay.
Yeah.
Quick and okay. Very quick report. Look at the CBC. Look at the hemoglobin. Once you see the hemoglobin, if it is low, look at the MCV. That's the first thing that you do. Once you see the hemoglobin, look at the WBC, look at the platelet count. Especially in monsoon fevers, you can get bicytopenia, monocytopenia, pancytopenia. So each form of cytopenia is important. And once you have looked at the WBC count, look at the differential count. Obviously, these are all obvious things, but sometimes you see a WBC count of 24,000, you don't really look at the differential count quickly. You assume a bacterial infection and a neutrophilia, and sometimes you'll be surprised that eosinophil percentage is 80%, or the lymphocyte percent is 80% in a WBC count of 24,000. So don't miss. And if you're lazy or if you're too many CBC reports to see through the day, just put the CBC on ChatGPT or Perplexity and let it do the. So just ask. This is a CBC report. What do you see? And that they will tell you. Okay, don't miss this. Don't miss that. But I'm not. Don't rely too much on these things because that will dull your prowess of analyzing reports. Yeah.
Thank you so much for a quick recap on the session of how to see a CBC report. Does Menzer index help in thalassemia minor?
So Menzer index is a very quick way of finding out whether we are dealing with uh, iron deficiency or thalassemia minor. Important thing to know is Menzer index should be calculated only when there is microcytic anemia. If you start calculating it in macrocytic anemia of B12 deficiency, that is nonsense. You will get 102 MCV and 3 lakh the RBC count. Menzer index has no meaning. As you know, Menzer index basically tells us that whether the microcytic anemia is probably due to thalassemia minor trait or due to iron deficiency anemia. So a Menzer index, which is MCV upon RBC count, uh, Menzer index is basically less than 12 in thalassemia minor, more than 13 in iron deficiency, and a level between 12 and 13 could be either. It's a rough index. I know hematologists who don't like it at all, the Menzer index, but at the same time, I think it's a very handy, quick tool to judge whether this patient needs a hemoglobin electrophoresis or whether the patient needs a serum ferritin or serum iron studies.
Yes, sir. Thank you so much. One last question here by Dr. Batulio is if a patient on clopidogrel who requires voriconazole for fungal infection, why does the interaction make clinicians prefer prasugrel or ticagrelor despite similar cost and the bleeding risk?
I will have to first of all find out, does voriconazole inhibit CYP3A4? You'll have to tell me, Dr. Batul, whether this is related to CYP3A4 or not. Uh, for example, clopidogrel I know is a prodrug, meaning clopidogrel has to be activated by CYP to be able to function. Whereas the other drugs, that is prasugrel and ticagrelor, are not prodrugs. So obviously that conversion from prodrug to active drug will be mediated by a CYP enzyme. And I don't know what voriconazole does to the CYPs related to clopidogrel. If you know, do tell me.
So that is all the questions we have for today.
Okay,
And thank you so much for answering them. And
my pleasure. My pleasure, absolutely.
yes. Dr. Batula said voriconazole is a CYP2C19 inhibitor.
And therefore clopidogrel is converted to an active drug by that. So activity, yeah. Then I agree with you, Dr. Batul. Thank you for informing me that clopidogrel will not be converted to its active form because of CYP 2C19 inhibition, and 2C19 activates clopidogrel. Absolutely fantastic. Thank you so much.
Thank you so much, sir. And thank you so much, everyone, for joining us for this first brand new session of Solvent Medicine. And we hope you enjoyed this interactive Sherlock style medical mystery format and learning through the cases and the clues. And thank you so much, sir, for making learning so interactive and fun.